time to share some of the data I've collected so far for my new project on pain management in Morocco. And then also to kind of ask for your help in thinking about how to frame this moving forward, especially given some recent developments that that have happened, excuse me. And so it's really hopefully a time that I can workshop some ideas. And so any feedback, comments are extremely welcome on this. So I'll share with you a bit, and then hopefully I'm really looking forward to your feedback on this. So I'm going to start with the kind of typical ethnographic vignette and move on from there. So in 2018, I had the opportunity to talk with a research fellow who I will call Zainab at the National School of Public Health in Morocco. And the National School was created in 1989 by the Ministry of Health. And one part of its mission is to support the Moroccan healthcare system by sharing evidence collected through faculty research and PhD programs that can be used then to inform policy and also to improve the healthcare system's performance. And there's also a research institute that is associated with it as well. Zainab has researched and written about the development and implementation of a pilot project on palliative care in the Rabat region. So I should also say that the school is located in the capital city of Rabat. She and her team evaluated the project between 2016 and 2017 and documented its strengths as well as areas of improvement, such as lack of resources to sustain the program and to expand it to other regions, the lack of palliative care being integrated into hospitals and primary health care, the regulations surrounding aspects of palliative care that prevent it from being accessible to all Moroccans, and to improve the training for healthcare providers in the field and communication between all of the actors involved. So when I say palliative care, it is the treatment of pain is one part of it. It's really kind of managing symptoms. And so here in the United States, for instance, we have physicians who particularly train in palliative care that are palliative care specialists, but geriatrics as well as palliative care are not specialties in Morocco. But access to all communication. This was all interesting to me, but what struck me the most was when she said to me, pain is about politics. I asked her why this is and what she meant by it. She explained, before I came here, I was a family physician. I worked on the periphery of Rabat in a public clinic, so one that's run through the Ministry of Health. People came to me because of pain. Do you know what one of the most common complaints was of my patients? Pain. Pain from work, pain from physical labor. Yes, some were sick. They were not rich people. I did not have the resources to give them anything beyond what they could find in a pharmacy on the shelves. I couldn't help them. This was nothing about me as a doctor. I wanted to help them. It was because the government didn't give me the resources I needed. And even if I could have prescribed them something stronger, they wouldn't have found it in the local pharmacy because we weren't in a city. I had returned to Morocco in 2014 to explore how end-of-life care unfolds. So my first project I wrapped in 2009, and then 2014 was my first fieldwork trip again. And then I returned to continue this work in 2015 and 2018. And I had planned to be there all of the summer of 2020, but that has been postponed to 2022 because of the pandemic. So I'll be there again all next summer for fieldwork. When I went back, the first thing I did was to reach out to my contacts from my prior work on reproductive health care to ask them about their experience with end-of-life care. Maybe it was a loved one or a family member. One of my contacts, Layla, told me about the recent death of a loved one. It was her brother's mother-in-law. And I just want to say that I'm just using pseudonyms to protect my participants. Layla recalled how she became very sick very fast, the mother-in-law. She said the physicians and nurses at the hospital spoke very fast and used a lot of scientific terms with little explanation to the family. Layla told me that they would not administer medication to control her brother's mother-in-law's pain. I inquired, was the family asking for her to have pain medication? Layla responded, yes, they did, and the staff said they were taking care of it, but we really didn't have that impression. They also said, quote, in Muslim countries, we want people who are dying to be aware, and we don't have the right to administer pain medications that will help them feel more comfortable, end quote. I asked Layla why the pain was good or needed. She stated, they actually said two things that were, she stated, they actually said two things that were contradictory. First, they refused to tell the family that she was dying. This was in God's hands, and they couldn't do anything about it. They couldn't say she was dying because a miracle could always happen. But at the same time, they refused to give her pain medication because they said it's basically what we do here in Morocco. We can't help them to die in peace because they want them to be aware. It's between her and God. Layla said towards the end of our conversation, I grew up in Morocco. I'm Moroccan. I honestly never knew about this. I never thought that someone who was ill and really in pain couldn't get pain medication because they were dying. I was totally baffled. After speaking with my friends and contacts from my prior field work, reading the literature and seeing Human Rights Watch highlight that the palliative care crisis in Morocco, which I'll talk about in a moment, I became more focused on pain management during end-of-life care, but the story doesn't end there. I followed up on some of the points that Layla raised with Dr. Alawi. He told me that, quote, it's normal that people suffer a little bit after an operation. I am one of the rare doctors who uses morphine, for instance, for my patients, because for cardiac patients, it's very important. He's a cardiovascular surgeon. And it's amazing since for more than a year, we have had a hard time finding morphine in Morocco. Morphine was first introduced in Morocco in 1995. An article from the Annals of Oncology noted that in Morocco, 6 of the 7 essential opioids of the International Association for Hospice and Palliative Care in African countries were available. So these include immediate release oral morphine, controlled release oral morphine, injectable morphine, fentanyl, which is the patch, and oral methadone. The one not available was the oral immediate release oxycodone. Dr. Alawi hypothesized it was because the laboratory isn't very interested in selling morphine because it is very cheap. It's not money making. Dr. Alawi practices in a private hospital that sees both Moroccan and international patients. It is highly regarded in the local region. He talked about how care has changed in the country. In quote, in recent years, more than 50% of the treatments are now provided in private clinics, I think. Things are changing. In private clinic or hospital, the patients pay. They have more money and they want to have a good image, so they don't want to leave the patient suffering. It's business. The best medicine is done in the private hospitals now, not in the public hospitals. The public hospitals are very poor. They have nothing. At this point, I'm starting to see cracks in the system that extend far beyond cultural and religious beliefs about the body, pain, and illness. A lower fertility rate coupled with longer life expectancy means the population in Morocco has started to age faster than in the past. Lower fertility rate with faster in the past. The country's aging population has received little attention from researchers. However, the population aged 55 and over is now growing faster than the total population. With an aging population, there's a shift in disease burden, typically we see, from infectious diseases to non-communicable diseases, or I might call them NCDs. That includes cardiovascular and respiratory diseases, diabetes, and cancers. Human Rights Watch published a report on the state of palliative care in Morocco in 2016, shortly after I began my fieldwork. It states, every year, more than 150,000 Moroccans face advanced and often incurable chronic illnesses. Over 62,000 Moroccans suffering from these illnesses will experience debilitating symptoms such as pain, breathlessness, and depression. It notes 75% of yearly deaths in Morocco are from NCDs, and the burden of chronic illness is likely to rise given the percentage of people over 65. The segment most affected by these illnesses is expected to nearly double in the next 15 years. Palliative care, as I said before, the relief from symptoms and pain, including the use of medications, is not widely offered in Morocco. The result is that tens of thousands of Moroccans with life-limiting illnesses pass their last weeks and months in great unnecessary suffering. This was confirmed by another physician, Dr. Ben Said, who told me palliative care is not used enough in Morocco or even used at all in some centers. Dying patients often die at home because no place will accept them. And I'll get into that in a minute as to why that may be. Few hospitals have dedicated palliative care units, and those that do exist are usually connected to oncology and in major cities. But the WHO estimates that 70% of adults in the region needing palliative care suffer from illnesses other than cancer. Dr. Ben Said also made this observation about who has access to resources and care. Intensive care units and oncology departments prefer patients with curable diseases than patients who will occupy the available beds and die there. The Moroccan government has tried to improve palliative care by implementing national policies, revising medical school curriculum in 2015 to include a unit on palliative care, and relaxing regulations for the prescription of opioids, more specifically morphine. And more on this in just a minute. I'll talk about a little bit of how the regulations have been relaxed, but still remain strict and restrict access. I want to make a note here about the curriculum revision. This only includes 20 hours of classwork on palliative care, and that's even fewer hours given that palliative care is a set of practices. That's even fewer hours on actual management of pain. Dr. Mazrouk, an oncologist who's based in Marrakesh, explained to me that this is just not enough. And she also stated that it doesn't include any simulations. So it's only students who are in the classroom learning about pain management and palliative care. So this is why she and a small team at her hospital has developed a 3-day simulation for medical students that includes them coming to the hospital to learn about the proper dosing of pain medication. The medical school curriculum was only recently revised, so physicians in practice for longer may be fearful of opioids or prescribing opioids because they never learned about their uses, effects, or dosing. And so this was actually when I first began my field work. There is a palliative care association that was started in Morocco, and I was speaking to the founder, and who is a physician who practices at a private clinic in Casablanca. And he had talked to me about this fear that physicians actually have about prescribing opioids because they never learned about proper dosing. And so those that do, and I'll talk about the kind of how they can actually, provide morphine, for example, or morphine, they tend to actually underdose the patient. So they're actually not really helping. They're actually giving too little medication in order to control the pain. However, physicians must have a special permit to prescribe opioids and write prescriptions on pads from the Ministry of Health. And usually these pads are only distributed at the regional office. So it's not that you can just get them anywhere. You have to go to the regional office of the Ministry of Health to get these special prescription pads in order to write for opioids. And only a fraction of physicians actually go through the necessary steps to prescribe opioids. I was in the office of Dr. Schreiby, an oncologist based in Rabat at a public hospital. When we started to talk about this license that is needed to prescribe opioids, she stood up from her desk and walked over to a cabinet with 2 doors. So it's a cabinet. It was taller than she was. It had 2 doors, and she opened it up. It was a metal cabinet. And she opened it up to show me stacks upon stacks of the notepads that she has used to write prescriptions for oral morphine. She must retain the carbon copy for a set number of years. I believe it's 5 years, but I'm going to double check that. Patients must also obtain opioids in person, and often only urban pharmacies stock them, making filling a prescription difficult for sick patients. So this was also similar to Zainab's complaint, because not all pharmacies would stock oral morphine, for instance. So they would have to travel to a city center. They typically it's only in the pharmacies typically around wherever the hospital is. Typically where I'm working, kind of a large teaching hospital located in that area, but you don't find it in every pharmacy. And so you also, even though they've relaxed regulations, they are now able to provide a 7-day supply instead of a 3-day supply. You still have to go in person. You have to get it yourself. You can't send someone else to pick up your prescription, which makes it very difficult, particularly for those who are traveling. And Dr. Mesrouk brought that up too, because she works in Marrakesh, and she works at a hospital that treats many of those who live on the periphery and who are uninsured. And so she said it makes it very difficult for them to be able to actually get, if she gives a prescription to send them home with, it's actually very, very difficult, because if they have, stage 4 cancer, it's very hard for them to return to be able to actually get the prescription themselves. Okay, so she said this, Dr. Ben Said explained to me, the center where I work, which is in a city center, gives a lot of painkillers like opioids, whether injectable or oral. We also support patients at the end of their life with sedative hypnotics, which put them to sleep when the pain no longer responds to opioids, or when the suffering cannot be relieved by morphine, such as feeling the pressure of a tumor or respiratory distress if in lung cancer, for instance. But this is a luxury, quote, luxury that we offer to our patients. It is not the same in other centers in Morocco. The vast majority of oncology centers in Morocco distribute a small amount of opioid in the hospital, but rarely outpatient. And this is the one thing about the palliative care, the pilot project that Zainab helped to evaluate, was this was actually one of the first outpatient palliative care projects in Morocco. So this is where they actually did home visits, for instance. So we might think here in the US of hospice visits. It was similar, but it was actually one of the first ones in the country, if not the first one in the country. The vast majority of oncology centers distribute a small amount of opioid in hospital, but rarely outpatient, and end-of-life support by hypnotics is almost non-existent. Doctors generally urge the family to keep the dying patient at home until his or her death. And one thing I've been reading more recently is that illegal use of synthetic or opioid tramadol produced in Europe and Nigeria has actually been on the rise in North Africa. Although there is a localized, what they call a heroin epidemic currently, particularly on the rise in the northern part of Morocco, more so than opioid abuse. As I stated a few minutes ago, I am most interested in the use of prescription opioids to control pain during chronic and terminal illness in Morocco. So I had first started in thinking just about end-of-life care, just about terminal illness. But then I found how much chronic illness that also is accompanied by pain is actually not treated. And so like physicians like Zainab, but also others, which I'll talk about in a moment, who say that we don't treat cancer patients predominantly. We don't work in oncology. We might be in family medicine or such. They don't particularly have access to the same resources that those who do work in oncology have for pain medication. So I found this discrepancy to be very interesting and somewhat vexing, and to how to particularly figure this all out. I've been interested in analyzing physical pain and suffering and the use of pain medication within the larger sociopolitical and economic context of Morocco, given the government closely monitors opioid prescription and distributes most resources for pain management to cancer centers. So what was interesting is when I was sitting in, I'll talk about this team in the emergency department that I work with, and I was sitting and I was with their pharmacist at the hospital, and I was talking about my project and things, and the pharmacist had asked me, this was kind of at the time of the opioid crisis here in the United States, and he asked me about it. And one of the other physicians said, well, how is that possible? Because they're so regulated. And we can think about the illegal trafficking and trade, of course, but it was very kind of stunning to her because there's so many strict regulations, particularly about the physicians who can prescribe the opioids that they have to go through in order to do so, that she was kind of shocked that there was this crisis that was happening in parts of the United States. So closely monitors opioid prescriptions and distributes most of its resources for pain management to cancer centers. The connection to oncology caught my attention when I was speaking with a team of physicians who work in an emergency department at a hospital in Rabat. They noted the presence of the Leila Selma Foundation for the Prevention and Care of Cancer, and she is the wife of King Mohammed VI, established in 2005. The cost of cancer is high, and the situation in Morocco is worrisome, given that it's estimated 2/3 of the population does not have medical coverage. The results of studies on the cost, kind of impact studies, on the costs related to cancer care are sufficient proof of the heavy burden incurred by households, as well as the severe social and economic repercussions of cancer. Something I'm interested in doing is examining how the state and the politicization of pain and bureaucracy impact the ways that people suffer and experience their bodies during illness. As the physicians noted to me, because of the foundation and the interest of Princess Leila Salma in the prevention and treatment of cancer, recently established palliative care units are connected to oncology. And while, yes, it is very true that certainly this is a very important part of cancer care, is also managing symptoms and pain. That is not denying that whatsoever. But this leaves many Moroccans who do not have cancer, such as those seen in the ED or by physicians like Zeynep in primary care, still suffer from pain, unable to access pain treatment. And so it almost seems like there's an inclusion and exclusion here as to whose pain counts or whose pain matters. I'm thinking about notions of biological citizenship. So kind of, again, this is why I didn't just stick with end of life care and oncology, but also looking at those who have pain that don't fall in these categories and how they are treated. From what I have found, there is little ethnographic work on pain associated with NCDs in the Middle East and North Africa, given the region is on average younger than others. Scholars have focused more on infectious disease, reproduction, traditional healing, and biomedicine. Christine Nutter studied pain and discipline during childhood in Morocco, but from a human development perspective. More research is needed on suffering and pain management during chronic and terminal illness in Morocco, given its population is aging faster than before, and more people are dying from NCDs, which may have prolonged periods of pain before death. On a theoretical level, I want to take a different approach to the study of pain than most anthropologists and social scientists. And I'm thinking of work by like Mara Buckbinder on pediatric pain, for instance. I draw on approaches from historical and political anthropology. I'm thinking Alana Feldman, Bill Maurer, Annalise Riles, to make the artifacts of institutional life, policies, documents, reports, educational practices, and institutional discourses, main objects of inquiry when it comes to analyzing how people suffer with pain. So for instance, I became very fascinated with these notepads. Like I wanted to know where they were kept. I wanted to know how the physicians got them on these special notepads. I'm also very interested, for instance, in the license that they needed. So I became kind of fixated on these actual tangible objects that kind of have all of these layers, institutional layers associated with them. So I kind of want to say, like, I have an interest in trying to make these kind of items, things, I'm not sure how I want to call them yet. I kind of want to make them the focus. Typically, when we think of what I've read, and I welcome other, maybe I don't know of particular research, but what I have read, it's a lot of focus on the experience of pain. And I really want to make these types of objects kind of my focus. So for instance, whenever I went to a doctor's office and I knew they had these notepads, for instance, Dr. Alawi, because he's run, as he said, he's actually one of the rare surgeons that that use morphine. Typically, some of his colleagues would send home with what our equivalent of Tylenol would be. And so, like, I wanted to know, like, where do you keep the notepads? Like, do you have them? Like, and then like the license, like, is it a card? Like, what do you do to get it? Like, I became their certificate saying that you can prescribe opioids. Like, I became very fascinated by these types of kind of things left behind, the actual packaging. One thing I asked the pharmacist is I wanted to know where oral morphine is manufactured. I wanted to know, is it coming into the country? Do they import it? He said, no, it's actually manufactured outside the Casablanca. I became very interested in like the packaging too. So those types of things. And I'm wondering if there's a way that I can explore that. So I'd love to hear some thoughts on that. These are oftentimes seen as the backdrop of research on illness and the body, but rather I see these, quote, artifacts as inherently linked to suffering and shaping how Moroccans experience pain. I also examine, or something such as my friend Layla had brought up, how pain and suffering intersect with Islamic beliefs about death and illness in Morocco, in addition to beliefs of mortality and sin. I explore how a sense of self and personhood is connected to the use of pain medication, as some families from my previous field work in Morocco expressed that loved ones, like Layla, were denied pain medication during the end of life because providers said Muslims are not to use opioids since they can make patients lose connection to the world and their bodies. And I also had the chance to speak with a woman who runs a support group for those who particularly have aging parents. And it was very interesting because when I talked to her, maybe think of sometimes you'll see like a hospital chaplain come around to different rooms, we think here in the US. Kind of very similar, where she would work with patients with aging parents, kind of support them through the process if their parent was in the hospital and such. And the one thing that she talked very similarly about this. She said, we lose connection to ourselves, we lose the sense of self, we shouldn't use it. The doctors they were very careful in that distinction. There's the opioids, like we can think of oxycodone or morphine, but then there's also the hypnotics, right? Or the medications that will actually help put people to sleep. And they were very careful of those distinctions because the ones that were putting people to sleep, such as Ben Said, said very, very much against it because it might think of ideas of euthanasia, for instance. So they're also I want to be clear that I'm interested particularly in this use of opioids. We can think of morphine or oxycodone and such. But again, there's this other, they class them as sedative and hypnotics. There's also that class that is used sometimes as well. As Dr. Ben Said said, once the pain, if there's the pressure of a tumor, for instance, and such, and the pain stops reacting to opioids, they might choose to use or pursue the kind of the other routes as well. So there is that distinction too that I want to be careful about. These two lines are not particularly separate, given Morocco operates under secular and Islamic law, and 99% of the population is Muslim. The PJD, or it's the party that has been in power since 2011, which uses interpretations of Islam to develop legislation. So moreover, after September of 2001, Morocco has implemented religious bureaucracy to define and disseminate Islam. So I don't see these as two particularly separate parts of inquiry, but I'm still trying to figure out how exactly to bring them together, maybe, because as Layla, in the story of Layla, it doesn't seem to be particularly separate. They are kind of connected, but I'm still trying to flesh that out a little bit there. So that's what I have prepared based upon what I've done so far. And I'm really, welcome any comments and suggestions as feedback as I move forward, as I go to do field work in 2022 in the ED in Rabat, and then in oncology in Marrakesh. Those are my two main sites. So I'd really welcome any feedback or comments to move this forward. So thank you for listening.
Thank you very much, Dr. Rinker. That's extremely interesting. We open the Q&A session. Okay, I guess Jennifer has a question. Okay, no, it's not a question. So any comments and questions?
But thank you, Jen, very much.
I mean, I can start. I have several questions, and then we can, as our audience is thinking. So I am always fascinated by medical anthropology, but you have a lot of interesting details, and I kind of support your emphasis on materiality of all of these, like documents and certificates, and I think that's a very interesting direction to move with, to understand, how people approach these issues. But I was also thinking more about the culture stuff that we anthropologists are obsessed with, right? So on the one hand, you brought different things about Islam, quote unquote. I'm assuming there is something dialogical here when they address you as someone coming from a non-Muslim country, when they generalize themselves as, we in Muslim societies. So I'm assuming someone Muslim from, Syria or Iraq or another country goes there. I am not sure that they would identify themselves as Muslim societies. I would think they would rather identify themselves as like, Morocco or Moroccans, right? That was my experience in Syria and Lebanon. They were never like Muslim. They never emphasize their Muslimness, but they always highlight we Syrians, we Lebanese. So I was wondering if there's anything you encountered, because you have been doing research in Morocco for a long time, that they highlight something specifically Moroccan on top of being Muslim, and how do these two things converge or diverge when it comes to palliative care? Do they refer to any ritual specifically Moroccan, or did you find any particularly interesting historical moments in the previous decades that kind of how people invoke when they are talking about the palliative care, like something like, something happened in 76 to this patient, and then since then we are hesitant. So is there any kind of historical narrative that supports this hesitancy to use opioids? And another thing that I have is this whole idea of suffering as virtue. Some Muslim groups that I observe as having. Did you encounter that kind of a narrative as well? Because there's this idea that I hear from some people in Turkey, for instance, that, when you are sick, if you be patient and submit to God, it would help you heal from your sins, right? So it's there's some sort of a virtue in having the pain, because usually typically in the Western discourse, like pain is bad, right? We need to avoid it, whatever means it takes. So is there any kind of formulation of suffering and pain as a virtue? And last quick question is, are there any non-medicalized means of care management? Like I know you focus on specifically on the medical context, but I was wondering also if the local population, because you have been working with them for so long, are using different means. It can be using, I don't know, different imams or some other techniques of taking care of medicine. So this is a lot of questions, Cortney, but I'm really fascinated with all these details.
No, thank you. So yes, I'll go with like the second first about the suffering as virtuous. So yes, when I was speaking with several different physicians in particular, I'll start with them, physicians in particular, this is what they first brought up, is this idea of pain as being virtuous, as healing from sin, as being aware of your mortality, right? And, and their comment was that this is just, basically they were kind of appalled by it. They're like, we shouldn't be suffering. We have this these things accessible to us. Why are people suffering? So they were very different. And also the woman who runs the support group for those with aging parents took up this very similar line of this suffering is virtuous and such. So yes, I've absolutely heard that. In some of the wider studies, so the founder of the Palliative Care Association has kind of published on this, and actually in kind of his broader work on palliative care in Morocco also mentions this, particularly like cancer, for instance. You have cancer because you did something bad in the past, right? Like that's kind of, those things were certainly founded, or certainly found, excuse me, as well. And then in terms of historical periods, I can't pinpoint a particular time in terms of the healthcare system. So morphine was introduced around 1995. So this is when we started to see it first being used. There definitely was a shift, right, when King Mohammed VI took the throne as well, kind of a shift in how kind of society even operated compared to his father in the late 90s. So, I mean, that's one, but the one thing that has been documented in particular is this idea of like this morphine phobia, which is this because prior to 2015, it wasn't in the medical school curriculum. Like this, I think we're kind of almost living in a historical period to where it's not that something happened in this year and that's why I don't want to give, these opioid, kind of like a heavier pain medication. It's that nothing happened. We didn't have it, nor did we even learn how to use it. And so that's why I don't, that's the kind of thinking as to why there's not a lot of prescribing. But then we have to kind of think back to something that I wanted to dig into more, which is why I was asking the physicians, like, where is it manufactured and things like that, is I have some information and I really want to get into the archives as well, but I want to be looking at where these policies first came about. Like, why was it only a 3-day regulation, since when did it come about? Who created it? There's actually now a society just for the pharmaceutical, it's like the Society of the Pharmaceutical Industry or something. I forget exactly how they term it, but they're really seeing this as now Morocco as being a place where these kind of generic drugs can actually be produced. They say that we have the infrastructure so that we can be exporting as well. But now they have this kind of created. So I would say, something that people had talked about to me was that, thinking in times under, King Hassan II, the current king's father, is that there were these kind of what they call like the Black years, right? Where we think about torture and such like that and missing. And, they compared this, it's not that kind of pain, but it's almost that kind of pain. It's because we're still suffering, except now it's in this institutional structure. Like now it's in this healthcare system, right? It's supposed to be like this place that we're supposed to be helped. And that's not actually happening. So it's like we're still enduring this pain, but it's just this different type of pain too about that. So that's a little bit about the historical. So I'm almost thinking like, I think that's really interesting to think. Like I almost think like now we're kind of in this historical moment of where we're starting to see these shifts. And then in terms of the kind of we do this, I mean, this is what Layla had said that the doctor had told her, like we kind of do this, but something very specific, which is Moroccan, kind of thinking about, and this kind of goes with like the Moroccan rituals and the non-medicalized. Absolutely. I've heard people of going to the sand dunes, perhaps on the Algerian border, right? Because the sand is supposed to be very good for your health and immersing themselves. So there are these other ways. Something that I want to dig into a bit more is, I had mentioned a little bit about tramadol, the synthetic opioid being on the rise, where in Morocco, it's heroin and cannabis. And so with, large producers in places like Chefchaouen and such. So I'm almost kind of thinking that that might be something I need to start exploring a bit more, almost like what we're seeing, with this alternative mean. So I don't know exactly. but yes, there certainly were particular places, and also how Moroccan, my Moroccan interlocutors just talked about Islam in general. It was very much like this, even though, Burke has written about how Moroccan Islam was created by the French, right? But they still have this idea of there is this Moroccan Islam, very Sufi based, right? Very spiritual, connected to the body, right? Like those types of things. So yes, so that was also part of it in some of the discourse as well, as to what is kind of the Moroccan-ness, I guess, if you want to say about it. But yeah, but actually this is just something I've come across very recently with the tramadol and with the cannabis and stuff. So I'm thinking that's something I might need to explore a bit more, because if you have this population, like this inclusion and exclusion, if you have this population that's kind of excluded from the like legal institutional means to get this pain medication, are they turning somewhere? Like I want to explore those types of questions. I'm not quite sure yet, but it's something that came to my attention recently this year.
This is a very thorough answer. Thank you so much, Dr. Rinker. There's a question by Ahmed in the chat box. Would you like to read it? And
Oh, carrying the burden of terminal illness thing came up. Oh, no, I think it's I think it's a great point. I do think in some of the conversations that I've had, and also in some of the literature that's been written on kind of palliative care and such, there has been this talk about terminal illnesses. It's kind of, as I had mentioned before, so there's kind of a couple of different themes. So the one is kind of this idea of terminal illness as being something that, kind of the retribution for something that you did in the past. That was something that was raised, kind of this idea of sin and such. But then also this idea of bearing this illness in terms of like relation to others. So relation to the family, relation to kin and caregiving, because you'll look to them as, because of the institutional structure, to where if you have, and they've actually found such, like, for instance, like women have tended to present later for breast cancer. And so in some of the studies in Morocco, which means it's kind of past treatment or it has metastasized. And so this idea too, with then also this institutional structure to where they will only, they want to accept those that will benefit from the treatments. They want to, because they invest the resources that they have and exclude others. There's a lot more that's being put on kin and family networks in order to care for the dying. So there was kind of discussed of those types of burdens, like with Dr. Ben Said, for instance. It's because, if these don't, it's not that, yes, sometimes we just don't have the space, but sometimes like if you're presenting too far along, you're not going to benefit. So we're going to send you home. Well, who are we sending you home to? Right. So then there's this idea of kind of feeling the burden also of the care and such, and of the dying person, of the, the person who has the illness, who then has to go home. So certainly there was discussion of kind of thinking about it in a relational sense, in terms of burdens. Yeah, I would say that kind of more of a relation as to where the care would then take place afterwards. Yes, thank you.
I guess I do have one, Professor Rinker.
Oh, yes, please.
So I guess it's two parts. One is, you had mentioned that the one doctor was kind of shocked that there was an epidemic in the United States, and how could that happen if it's so regulated?
Right.
Are they worried that if they start introducing more, that they will fall victim to some of those same kind of statistics that we've seen? And then also, is that because, since you were saying they're produced domestically in Morocco, that it's not so privatized and money driven like maybe our United States pharmaceuticals are, to the point where they might not have that issue? Or is it still concerning?
No, I think that's a really good point. It's something that I as I said, I wanted to really explore this more, is that I do think there is this concern of widespread, and I won't say widespread, but there's this concern of a kind of opioid abuse, right, that we see here for numerous reasons. Those who are actually sick who just can't get the medications they need versus those who do it for other reasons, right? So I definitely do think there is this concern. And then the production domestically, I do think, and part of my plan for the summer was actually to be with the pharmacist. I was actually going to hopefully do some interviews with the pharmaceutical industry, with the Society for Pharmaceuticals and such, and also the government agencies that monitor the import, export, distribution of pharmaceuticals, and to talk about opioids. Is I also think they see this as a way of Morocco being kind of a central figure, particularly in North Africa and in Africa in general, in terms of producing medication. So the pharmacist said, I'm pretty sure they're manufactured in Casablanca. So that's something I need to investigate more. Like, I want to know exactly, but I had asked, where are they made? Are they imported? But I do think that, yes, I also see they kind of see this as an economic venture as well as perhaps to this production. So I'm also wondering, if that going to impact, they've relaxed the restrictions and regulations, but is that going to have any impact on it? I think it's something that we need to see what will happen as well in the future. But I do think there is a concern to prevent. I think that's particularly why these kind of very strict rules were kind of put in place first. Yeah. That's a good question. So yeah, so after I meet with the pharmaceutical industry, I'll have more next summer. Yeah, but that's something I want to explore more, is to kind of where they see themselves in this market too, in terms of their production. Yeah.
And those are presumably valid concerns, right? I mean, obviously we've had to deal with some of that. I mean, the end of life stuff is different than a 23-year-old who had shoulder surgery who then has to turn to heroin or something down the line. So there's different aspects of it, and obviously we're dealing with some problems too, but
yeah, that's
interesting. Thank you.
Yeah, absolutely. Yeah, and I think too, this is why you can see, I mean, something I'm very interested in is kind of this politicization of pain, because I also think that this too is why you see a lot of connected to the oncology. I think it's more than just having the foundation. I think is also, this is why we're connecting to oncology. These palliative care units are connected, is because, this is, as you said, kind of there is these discrepancies between these populations. Yes, I agree with that. But then at the same time, you have those who could benefit due to other reasons, right? And having the severe pain kind of being excluded from that, which then opens up, I think, some other questions, even ethical questions, right, about that as well. Sure. Wow, this is like a lot to think about. So thank you. It's been very helpful.
Other questions and comments? I can always fill in. I was wondering if there is a specific, if you observed any specific differences in terms of how doctors are practicing Islam, understanding and thinking about Islam. I'm thinking of, for instance, Shirin Hamdi's work. She compares how, Muslim doctors' understanding of Islam is kind of more secular and nationalist and Western compared to, the larger society and different groups in the society. So I'm wondering if you observed something similar in Morocco, in which kind of doctors are more trying to distinguish themselves as whatever, progressive Muslims or more westernized Muslims. Yeah. And does it kind of play into the whole discussion?
Oh, thank you for that question. There's actually something in the book I just wrote. That's actually one of the chapters. It's about the Muslim physicians here in the US, right? And because a lot of them talked about how their clinical training actually influenced the ways that they practice Islam and the ways that they believe. And so I think that's such a great question. Yes, I could definitely see that. Partly is because, so I mean, Morocco, I mean, a lot of the physicians I've worked with were trained in Morocco, but some also trained in Europe, for instance. So some also spent an extended period of time in places like Belgium or France. So to think about that, I think is really important. And so I have to kind of put a caveat too, is that I'm working in Rabat and Marrakesh. So I have to kind of put a caveat there that I'm working in the capital city, I'm working kind of in the tourist center. So I have to say that too, is that I think that gives kind of a Rabatness and a Marrakeshness to this project as well. So I want to just to make sure that that's out there and clear. Yes, I do think, and I think it was more of this idea. It's similar to Shireen Humphrey's work, but I also think it's because of their training as a physician. I also think it's what they see every day, that they see about, oh, okay, I'll get to Nova's question too in a minute. It's also about their training as a physician. It's also about what they see every day in the hospital too. In terms of experiences with patients who are very terminally sick or versus those who, in the emergency room, right? So those are two been very different. So I think it's really interesting to think about that. I would say in Morocco too, that they've seen, and I've also, as I said, some were not trained in Morocco. Some had lived in Europe for a particular amount of time. And so that could have also had an influence as well. But I do think their clinical training, what they went through, certainly has an impact on to how they view themselves as Muslim. So about the clinical training affecting, yes. So I can speak more on the project that I just completed here in the DC area, but it was really interesting because when I was talking to Muslim physicians who were treating patients towards the end of life, whether critical care or palliative care, it was really interesting to me that as they talked about their treatment of patients, particularly Muslim patients, as who came to the hospital, they talked a lot about themselves. And they talked a lot about how they believe, I want to say, how do I put this? It's not how they believe dictated the care that they provided. They actually said the opposite. They actually said that, what I believe, of course it is part of me and it's part of how I identify. But then at the same time, from what I see every day at the hospital, the interactions I have with the different types of families, Muslim or non-Muslim, and then also a lot of them talked about like empathy and such, they said that this really kind of transformed the way that I identify as Muslim and that what I believe. And they really saw it as this kind of very, dialogical, dialectic kind of process of being this physician. And I think a lot of it had to do with the fact that they were really getting into some of these really ethical and moral questions, particularly when they were thinking about end of life care. So, I found that even though they were treating patients, they were also, and we were talking about that, we were talking about the Muslim patients and families that they worked with, or I was observing a case that they were working on and being part of that, is that they actually reflected a lot on themselves. They actually took this as a time to be, very reflection. So I'll give two examples, the one of the US and the one in Morocco, where the one physician said to me, he's like, you, who identifies as Muslim, but he says, you must have think that I just got the faith beaten out of me. Like, that's how he felt, like being at the hospital, working, in critical care, that it kind of really just changed the way that he identified, but that he also saw the faith. He also saw Islam. In Morocco, Dr. Alawi told me, religion has no place in care. Like, I can believe what I want, but it has absolutely no place in care. So absolutely, I do think there is this connection between, their practice and then their religious faith, how they believe or being Muslim, or how they identify. Absolutely. Which I actually found to be, it was not something I expected going into this field work in DC, but a lot of their stories about Muslim patients were very much about themselves. Yeah.
Dr. Hamdani.
Oh, Sumaya, I think you're on mute, so I can't hear. Sorry.
There are many ways I'm unprepared for this presentation, trying to wrap my head around so many of the issues you've raised, and also trying to figure out how to, manage my screen. I'm fascinated by this particular subset. I was going to try to work up the courage to ask you about something else, but I'm going to go with this. This particular subset to your discussion about medical training affecting the way that these Muslim doctors practice their Islam, you said that it makes them much more self-aware as Muslims. But how does that, what does that mean?
Oh, I think what I meant to say was,
how does that how does that help them, or do they feel that it helps them be better doctors?
Right. I think what was interesting to me in this was when I started talking to particularly the Muslim physicians that I worked with here in DC, but also in Morocco, but I'll kind of stick with the DC region a bit more for this to answer this question, was that, you know, we were talking in particular about Muslim patient cases, because what happened was I observed the Muslim patient cases that they moved around, and then sometimes there were Muslim physicians who were the attending physicians or critical care. But we also just talked in general about what is it like to treat any patient, right, who's nearing the end of life or in tremendous pain or anything like that. And the conversation, while we were talking about the cases, it turned to much more of how they treated the body, you know, kind of like the person that was in front of them, the dying body that was in front of them, these different stages, really kind of informed the ways that they thought of themselves as being Muslim, but also about what they believed. And so one physician told me that it was an ever-changing process, and that he became much more kind of you know, he was always kind of taught that this is what I was to believe as a Muslim. And he said, now I kind of became much more of, this is what I believe as a Muslim. And so it was much more of this process of this kind of, you know, kind of like this self reflection, I think is what I said, is like the self-reflection of this. So it was very much a seeing, you know, I kind of connected it to the fact that they had to kind of, they're there to care for this person who's ultimately dying. And in that process, they really thought more about, what about suffering? What about illness? You know, this one physician talked to me about how he was taught, very similar to what we've been talking about before, and saw it in South Asia at home. You know, he saw that his family just, you know, they didn't turn to medication or anything like that to help their grandfather as you know, as he was dying. And he's like, then I see here, and I talk to other physicians, and I talk to other Muslim physicians, and I see that that's not how I should understand what Islam says about dying. Like, I should understand that God doesn't want to burden you. When you're sick, you should see a doctor. You should seek out this care. And so it really was this kind of cyclical process between being Muslim and then kind of seeing this, you know, what they deal with every day in their practice, kind of almost causing them to kind of rethink what they believe, what their faith is and such, or maybe reinterpreting some of those principles and those tenets.
So I'm sorry, but just so this physician that you're talking about, reflecting on the way his grandparents suffered versus the way he's dealing with patients that are suffering.
Right.
You're saying that his grandparents suffered because they opted to suffer? I mean, I would have thought that would just be a question of they didn't have access to medicine.
Right. Or there was also this, that this is how it should, this is like within the family, is that not seeking out, like this is, it's kind of like this tenet that where we said with Yasemin had brought up, is that the suffering is very virtuous. That there's this virtue in it. I mean, I've heard that. I've seen patients, you know, refuse opioids or pain medications because it's virtuous. This is not to lose the sense of self and the sense of control. And so he kind of took it as that this is what it should kind of appear as, right? This is just one example, and I'm happy to give others as well. But this is, you know, this is what it should kind of look like, almost like what Layla was told by the doctor, is that, you know, in, you know, Muslim countries, you're not supposed to give, or like Muslims in general are supposed to be aware of their bodies as they die, and, you know, and to be very connected. To where when he came to the US, he, you know, did his medical training here and everything else, and then he is practicing here. to where he said that it was no longer this thought that this is how it should be, but rather that I'm thinking that it's more that God doesn't want to see people suffering, that there shouldn't be this burden on the body emotionally, physically. There shouldn't be this burden on, like, for instance, if I kind of transmit this to Layla, you know, seeing this person suffering, I mean, it was very emotionally taxing for anybody to see that. And he's realizing that that's not what I should believe as a Muslim. Like, now I should, you know, I see, you know, so kind of, and then looking to find ways to kind of back up that claim, right? Like going to texts and imams, and also he also talked a lot about speaking to other Muslim physicians and seeking that. So I think I think access, of course, could be a question, but it's also about kind of how he framed it was kind of, that's how I thought it just should be, that's how death should take place for a Muslim, versus what I see here is.
I have to say, I mean, I guess it really depends on, you know, on which community,
Absolutely,
which
yeah.
region,
Mhm.
which particular.
Yeah.
I have never.
Oh, absolutely, yeah.
have never ever heard of anybody talking about pain as something that was equivalent
Mm-hmm.
to virtue,
Mm-hmm.
ever,
Mm-hmm.
on any level.
Right. And in
I mean,
and
I just anecdotally am aware of people in family and friends who, as they get older and confronted with terminal, you know, illnesses or decline,
yeah.
have opted themselves not to seek treatment
Mm-hmm.
because they felt that, you know, what's the point, and it's okay, and, you know, they felt, frankly, scared to death and overwhelmed of what treatment might involve, and they wanted to stick with what they knew.
Absolutely.
As opposed to kind of facing and confronting something that would be unintelligible and overwhelming. Doctors talking to you about this therapy and that therapy, you know. So they recoiled from treatment sometimes, just because the prospect of it was frightening and overwhelming. But
absolutely.
I
also heard a case. I also had a case in the hospital here where a family said, no, we don't, you know, the patient was unable to speak for themselves because their disease was just so far along. But to the point where they said, no, we don't want any opioids. We don't want this, you know, our loved one to have anything stronger than, you know, Tylenol or anything to take care of the pain. Because of Islam. Yeah. So no, I do. I mean, I'm not saying it was I mean, certainly that was not the overwhelming majority of cases I observed, right? That was not the overwhelming majority. But then when, for instance, the woman who runs the support group in Casablanca, you know, she talked to me about, you know, opioids, you know, think about when you take, if you've ever been given like Oxycontin or oxycodone or something, you get, you know, she's like, you lose this connection to yourself. And then what happens when you curse God for your illness, right? Because like you're not yourself when you take those. And so that's why you shouldn't. You should start with Tylenol. You should start with, you know, kind of these other products that are available. So there certainly was this, it wasn't don't seek anything. It wasn't don't seek any products, but it was this. And in some of the kind of bigger case studies of palliative care in Morocco, again, this was also found as this idea of coming back. Like, for instance, cancer is being, you have cancer because it's something, you know, you're kind of paying for it, or, you know, from something that you did earlier. There was, you know, that was not saying it was majority, right? But that it was available, you know, it was part of it. So
cancer is wow.
Like
so cancer is understood as a reflection of your sinful
sins for some, right? Yeah, no, I'm not saying for everyone. Again, as you said, it depends on the community. It depends upon it depends on the community. It depends on the what do I say? Like, you know, interpretation. We can think about fiqh. I mean, we can think about all of that, right? Like cultural context.
Maybe that's something that one should be careful of, just to kind of really be upfront about, sort of not presenting these as kind of, you know, Islam specific.
Oh, sure, right, yeah. Oh
because
no,
we
it's just that these
wanna-
are present, right? They're circulating, but it's absolutely not, right? Absolutely, yes. Be extremely careful, sure. Yeah, no, absolutely, I agree with that 100%. Yeah. Is there an Arabic word for chaplain? You know, what's interesting is that when I was writing it, it's, you know, in this context, it's actually the Islamic chaplaincy program at the University of Connecticut. I think it's University of Connecticut. I remember there's also one in California, but they adopt the word chaplain. So that's what I've used in the text. One reviewer asked why I wasn't using mufti, but I said they're not really giving any type of ruling, right? It's kind of very much this kind of translated, you know, kind of term. And the Muslim chaplains that I worked with, again, I could go back here, I didn't work with in Morocco, but, you know, they saw patients of all faiths. It was not just those who were Muslim, although they were called much more often to those who were Muslim because the other chaplains were Catholic, Methodist, and so they were called much more often. Yeah, absolutely.
May I kind of expand on that part?
Yes,
so
absolutely.
I just want to clarify. So you're saying you didn't see anyone in that kind of role in the hospitals in Morocco?
Right. No, that was
okay.
here in the DC area.
Do you think that is something that would ever exist? Or is that something because of like how, you know, what you spoke about, you know, the doctor's own practice of Islam, but also different views of religiosity and spirituality in Morocco? That's why they may not need a chaplain-like figure, because they themselves may be saying the same type of things that a chaplain would say. Do you think you got that kind of vibe from like being around the doctors in Morocco, or even hearing from patients?
Yeah, you know, I got it much more from kind of my contacts and the patients than from the physicians. And the physicians themselves said to me, you know, the medicine in Morocco is still very paternalistic. So it's very much still the doctors will tell you what to do. You know, that's kind of, you know, and you do it, right? Like it's still very paternalistic. And so, you know, in Morocco, they also, you know, they train men and women, right? There is some, so to be kind of these prayer leaders and, you know, and so I do think that there might be a possibility. And again, this kind of goes back to Yasemin's discussion of kind of what is Moroccan, you know, like what is specifically Moroccan, and maybe it could be something like this. You know, I kind of got it, but again, it was much more from the patients in the context than it was from the physicians. And I think part of that is just how the healthcare system and medical training occurs in Morocco.
And again, didn't you say you also met with physicians in Morocco that did train outside of Morocco and the Middle East, but they were still similar because they were operating in the context of people who were still trained in Morocco? Is that kind of how it works?
They would operate in the context, but they may have trained elsewhere. And so the one thing that was brought up by some of them is that palliative care is part of some of the medical school curriculum in other parts of the world, right? So they may have trained in a country where they did learn about palliative care, but then but then in Morocco, that's not a specialty. So a lot of times the palliative care specialists are actually anesthesiologists, or oncologists. Those are the two who do have some type. They do a palliative care association meeting. It's every other year. And so this is where they have nurses and such come to talk about you know, those who actually do administer some of the palliative care, maybe with these pilot projects, what they do, but then also would be about what they see in their everyday practice in order what resources are needed to build out palliative care as well. But it's not like here where you might have a specialty or a board certification in palliative care at all.
Yeah, that's basically what I was wondering. So thank you for clarifying that, because I even wondered, did they even have a term for palliative care in Arabic that they would make? But if they're using other like professions to kind of fill in for that, it would make sense that they wouldn't.
Right, right. But they do use, I mean, all the, and I didn't get into this all, but all the medical school curriculum is in French. So doctors are trained completely in French. And so this can actually also cause some types of translation problems when they're not, I mean, they're Moroccan, right? But they're kind of like immersed in this particular vocabulary, which is a French vocabulary. So yeah, so I know you're absolutely right, is I didn't get to that point, but that's also some of the issues I ran into my previous field work as well. Yeah. So I know we have to end, so thank you. Thank you so much to everyone. But yes, I know Yasemin has announcement, or I should know, has announced.
Thank you so much, Cortney. That was amazing. Thank you everyone for coming. We really enjoyed this exciting discussion. We look forward to the progressing of this research. Yes, Aisha, would you like to announce the next event?
Thank you. Thanks so much, Cortney and Yasemin. So an announcement for the next week. As you know, the second Ramadan during the pandemic has started this week. And Muslims observed the first Ramadan at the beginning of the lockdown last year, around April and May. So our next speaker will present on the experiences of Muslims in the UK during the Ramadan under lockdown. So it will be an interesting presentation. She will be joining us from Cardiff University in the UK. So please find the link in the chat section. Her presentation titled Ramadan in Lockdown, Personal Reflection and Communal Activities. So please register and join us for next week. And another announcement is the Meydan podcast. In March, the Center and the Meydan launched the Meydan podcast. That is a family of 4 thematic streams and explored Islamic studies through race, law, gender, knowledge production, and the Muslim periphery. So let me copy that information. Also, you can subscribe to the Meydan podcast. That is launched by the generous funding from the Henry Luce Foundation. So I just shared that information with you as well. Thank you everyone for joining.
Thanks, Cortney.
Thank you very much. Thank you.
Bye.
Please
Bye.
join me in thanking Dr. Rodney. Thank you so much.
Bye.